What is the role of inhaled corticosteroids in asthma? Inhaled corticosteroids are the first-line controller drugs in asthma. They reduce airway inflammation and hyperresponsiveness, leading to improved symptoms and lung function. They also decrease the frequency of exacerbations and are the cornerstone of long-term management. Why are beta-2 agonists preferred over beta-1 agonists in asthma? Beta-2 agonists selectively stimulate beta-2 receptors in bronchial smooth muscle, producing effective and targeted bronchodilation. Because of this selectivity, they have minimal beta-1 stimulation, resulting in far fewer cardiac side effects such as tachycardia. Beta-1 agonists primarily act on the heart, increasing heart rate and contractility. They do not provide useful bronchodilation and carry a significant risk of cardiovascular side effects, making them unsuitable for asthma therapy. What is status asthmaticus? Status asthmaticus is a severe life-threatening asthma exacerbation that does not respond adequately to standard initial therapy, for example, inhaled bronchodilators. It is characterized by unrelenting bronchospasm and airflow obstruction that fails to resolve with conventional bronchodilator treatment. Progressive hypoxia develops due to severe ventilation-perfusion mismatch. Hypercapnia may also occur as respiratory muscles fatigue. Requires immediate admission and aggressive management including systemic corticosteroids, IV bronchodilators, and possibly mechanical ventilation. What is the mechanism of action of theophylline? Theophylline primarily works by inhibiting phosphodiesterase, which leads to an increase in intracellular cyclic adenosine monophosphate in bronchial smooth muscle, resulting in bronchodilation. It also antagonizes adenosine receptors, thereby reducing bronchoconstriction and the release of inflammatory mediators from mast cells. Additionally, theophylline may improve diaphragmatic contractility and enhance respiratory drive, which is particularly useful in patients with respiratory muscle fatigue. What is the difference between expectorants and mucolytics? Expectorants increase the volume and hydration of bronchial secretions, making mucus easier to cough out. Mucolytics break down the structure of mucus like disulfide bonds, reducing its viscosity. Why are long-acting beta-2 agonists not used alone in asthma? Long-acting beta-2 agonists provide bronchodilation but do not treat underlying airway inflammation. Used alone, they can mask worsening disease, increasing the risk of severe exacerbations and death. Long-acting beta-2 agonists must always be combined with inhaled corticosteroids. ICS address the inflammatory component, while long-acting beta-2 agonists provide sustained bronchodilation, together forming a safe and effective regimen. Monotherapy with long-acting beta-2 agonists is contraindicated in asthma management. Role of leukotrienes in asthma. Leukotrienes are inflammatory mediators derived from the arachidonic acid pathway via the lipoxygenase pathway and play a central role in asthma. They cause bronchoconstriction, airway inflammation and edema, increased mucus secretion, and airway hyperresponsiveness, leading to airway obstruction. They are especially important in allergic and aspirin-induced asthma, forming the basis for therapy with drugs like montelukast. Why is theophylline rarely used now? Once a mainstay of asthma therapy, theophylline has largely fallen out of favor due to a combination of safety, pharmacokinetic, and practical concerns. Key limitations: narrow therapeutic index with a high risk of toxicity, requires regular serum level monitoring to avoid harm. Frequent adverse effects such as nausea, insomnia, and palpitations. Severe effects include arrhythmias and seizures. Unpredictable pharmacokinetics influenced by age, liver disease, and smoking. Multiple drug interactions with increased levels seen with erythromycin and ciprofloxacin and decreased levels with rifampicin and smoking. Availability of safer alternatives such as beta-2 agonists, inhaled corticosteroids, and leukotriene antagonists. Slower and less reliable action compared to inhaled bronchodilators. How do inhaled steroids reduce airway remodeling? Inhaled corticosteroids reduce airway remodeling primarily by suppressing chronic inflammation, which is the main driver of structural changes in the lungs. They suppress chronic inflammation, leading to reduced eosinophils and cytokines. Inhibit fibrosis, resulting in decreased TGF-beta and collagen deposition. Reduce smooth muscle hypertrophy, thereby preventing airway wall thickening. Decrease mucus gland hyperplasia, leading to reduced mucus secretion. Inhibit angiogenesis, resulting in reduced new vessel formation in mucosa. What is aspirin-induced asthma? Aspirin-induced asthma is a type of asthma in which aspirin and other non-steroidal anti-inflammatory agents precipitate bronchospasm, typically in susceptible individuals. Susceptible individuals often have underlying airway hypersensitivity. The condition is characterized by a reproducible reaction to aspirin and related non-steroidal anti-inflammatory agents, distinguishing it from typical allergic asthma. Mechanism: non-steroidal anti-inflammatory agents inhibit cyclooxygenase, leading to reduced prostaglandin production. This shifts arachidonic acid metabolism toward the lipoxygenase pathway, resulting in surge of leukotrienes, the key mediators of bronchoconstriction, mucus secretion, and airway edema. The classic triad: recurrent bronchospasm and airway hyperreactivity triggered by non-steroidal anti-inflammatory agents intake. Reproducible adverse reaction to aspirin and other non-steroidal anti-inflammatory agents. Patients commonly present with nasal polyps and chronic rhinitis or sinusitis. Asthma, aspirin sensitivity, and nasal polyps form the hallmark clinical presentation of aspirin-induced asthma, aiding diagnosis in susceptible patients. Management: strict avoidance of aspirin and all non-steroidal anti-inflammatory agents is the cornerstone of management. Paracetamol in low doses is a safer analgesic alternative for these patients. Montelukast is a key controller medication. In selected severe cases, aspirin desensitization may be considered under specialist supervision. What are biologics in asthma? Biologics for asthma are a class of lab-created monoclonal antibodies designed to treat moderate to severe asthma that remains uncontrolled despite the regular use of standard inhaled steroids and other controller medications. They disrupt the inflammatory cascade by binding to and neutralizing specific proteins or receptors involved in asthma pathogenesis. Patients with persistent, uncontrolled asthma despite optimized standard therapy, particularly those with eosinophilic or allergic phenotypes, are candidates for biologic therapy. Anti-IgE agent omalizumab blocks IgE, the antibody that triggers allergic reactions. Anti-IL-5 agents mepolizumab, rislizumab, benralizumab. They target IL-5, reducing eosinophil growth and survival. Anti-IL-4 and IL-13 agent dupilumab blocks signaling receptors for IL-4 and IL-13, reducing both allergic and eosinophilic inflammation. Anti-TSLP agent tezepelumab targets TSLP or thymic stromal lymphopoietin, an upstream molecule blocking inflammation early in the process.